Okay, well, thank you, Dr. Vassar and Dr. Hartwell and everyone for having me today. I think this is a great opportunity to have further discussions of how we can integrate faculty, staff, and students into our work. And so today I want to kind of talk about from a health disparities and community engaged approach of how we end these epidemics. And so today I'll be kind of discussing programs that we have related to HIV and STIs, COVID, and other social behavioral issues that are definitely influencing care continuums, and especially how we can then engage students within that work. And so kind of the primary focus within today for this discussion is to kind of highlight some of our team within both my lab here at the Sexual Health Research Lab, but also faculty at the Center for Rural Health. Some of the programs that or projects we've been doing based on community needs, and then rounding out with describing some of the current active programs that we have that students, faculty, staff, and the like could get involved with to enhance collaboration as well. And so just a little bit about me. I am here at the Department of Rural Health. I've been here for about 2 years, a little over 2 years now, and I was on main campus within our health education promotion program for about 4 years. My PhD is in health behavior, which is essentially health psychology, and we'll kind of talk through some of the various work that we do and kind of my trajectory there. Also with the Center for Rural Health, I think I want to highlight some numerous other faculty members that are kind of, we've all coalesced together to address some of these health disparities. So Dr. Wheeler has a large focus on program evaluation, secondary data analysis, more of a psychometrics perspective. Dr. Giano, who is a colleague with mine, who does quite a bit of work, does a lot of secondary data analysis with us, but has focused on adverse childhood experiences, youth and adolescent health. Dr. Schumacher, who does a lot of quality improvement work, and then has been moving into some recent studies looking at HPV vaccine, especially among the rural-urban continuum. And so we have this core group of faculty. If you go to our website anytime at sexualhealthresearch.org, you can highlight some of our faculty and staff partners, and also our research staff of students, 2 of those being Kyle DuBois and Hunter Myers, who started off, who are DO MPH students and started off our first year through the MPH as our GRAs, but continued to do work with us. And so I want to kind of ground some of the work we do in the way that we train students too, that we come from a practitioner, scholar, and advocate model, that we believe that as public health practitioners and also as physicians, that you have to have these 3 different identities within ourselves. So we need to have practice, medical practice or public health practice that is grounded in science. And our research questions are derived both from that experience as a practitioner, but also our observations. So things that you've already seen in clinics or things you've seen in your classes, based on those experiences might bring research questions to the forefront. We see that a lot with Dr. Vassar and his team looking at how things that are occurring within media, within society, or within research areas, how that then develops new questions that we have. We also have that overlap between our scholar and advocate, that we're examining these complex social issues and inequity, how these are the social determinants of health, and how we can then use that research to inform policy, having that advocate lens. And given that, especially physicians, those who are medical students that are on the call today, you have a unique role within especially if you're going to be rural practicing, but the communities that you're in, to be able to advocate for health changes. And so how we can also empower those community members to advocate for themselves. And so most of my work kind of falls under this larger lens around sexual health. And when we think about traditional views of sexuality, if you ask somebody what it means to be sexually healthy, the first thing that's going to come into mind is essentially, do I have an STI or HIV? Do I have an unwanted or unintended pregnancy? We kind of have that disease framework. But in reality, it's much more holistic. And so the World Health Organization looks at the fact that sexual health is physical, emotional, mental, and social, and all of this, how it's related to sexuality. So it's not just this mere absence of disease or dysfunction, but we as individuals have rights to safe and pleasurable experiences, and that in order to have attain sexual health, all of our rights as persons must be respected, protected, and fulfilled. And so this means that we need research that starts to look at larger factors related to sex and sexuality, and some of this with the social constructs or how sexuality is put within all of our social cultural norms, there becomes a role of place. And so within here at the Center for Rural Health, we're also looking at what is the rurality, suburbanness, and urbanity, and how that then impacts health disparities and health outcomes. And so there is this kind of debate of what is rural, what is urban. There's lots of classifications from the RUCO, which is the rural urban commuting area, to the index relative rurality, which we use, the USDA, that if you were to overlay these all on a map, there would be quite a few areas that wouldn't overlap with each other. And so we really have started this framework of looking at not is it classified as rural or as urban, moving from this dichotomous to more of a continuum of how rural is an area, given that we know that extreme rurality is absent from most areas of the United States. I do want to give this kind of caveat. We do a lot of research with rural Oklahoma. It just might not be our Joe Exotic version of especially LGBT work within Oklahoma. I will say that during COVID, given everything that was Joe Exotic on Twitter, we were running a large number of studies looking at sexual health of LGBT individuals within rural areas of the United States. And thanks to this, we got to use a lot of Twitter advertising and tying it back to Joe Exotic, who helped increase.
Now, you want me to put this back in there, or do you want to leave it out right now?
We might have someone that
might take a couple days to get these parts.
Yeah, go ahead and put it back in, and then I can definitely. So,
thank you. So just a little bit of humor, but yes, you know, we definitely, when we think about rural sexual health right now, Joe Exotic, bless his heart, it's not quite what we were going for, but definitely has been impactful. So some of the work that we've done and that we've been looking at is kind of this intersection of social and distal factors which influence health and healthcare disparities, especially within Oklahoma, but also within other rural communities beyond. And so when we take things like biases in healthcare, stigma and discrimination that occurs within the medical setting, but also within our community and at the individual level, and then mix these in with the social determinants of health, so things from structural stigma to things that have been ingrained within policy, to social norms and community norms related to individuals' behaviors. All of these coalesce together and then can directly impact the health outcomes of individuals or communities, but also can impact healthcare disparities. So who are engaging in care, who are not engaging in care, and what are those reasons why. And so that's been kind of a foundation of our work, is looking at some of these underserved and under-resourced communities within Oklahoma and other areas, and how that directly relates to care outcomes. In specific, we do a lot of work with sexual and gender minority populations, so LGBT health disparities. This is notable because within Healthy People 2020, which is our kind of our benchmarks every couple of years that comes from the Health and Human Services, have noted that LGBT youth are more likely to attempt suicide. There's a great deal that tend to be homeless. These populations tend to have higher rates of tobacco, alcohol, and other substance use. We know that especially sexual gender minority women are less likely to get preventative services for cancers, and then sexual minority women are more likely to be overweight or obese. And the research tells us is that a lot of these things like shame, stigma, access to affirming healthcare, structural level discrimination directly coincides with engagement behaviors that lead to a negative health outcome. And so we're interested in what are some of those behavior modification things that we can do and test to be efficacious, and then roll it out larger for intervention development. And another example we start to see this, and that I'll kind of touch on with work, is the role of HIV. So currently models related to HIV in the United States, if we kind of do business as usual, that when we model HIV risk of diagnosis among men who have sex with men, so gay, bisexual, and other men who have sex with men, that 1 in 2 or 50% of African-American men who have sex with men would be diagnosed with HIV in their lifetime. 1 in 4 Hispanic MSM would be diagnosed in their lifetime, and 1 in 11 white MSM would be diagnosed in their lifetime. We definitely see a huge disparity there of what things are occurring, how social norms have changed, discussions we've had about HIV, but also then where are we putting our resources and what does those resource allocations look like? And unfortunately, a lot of those resources have not gone to the southern jurisdiction or within rural areas. And recently that has changed a little bit as part of the larger Ending the HIV Epidemic program that HHS has put through. And so essentially looking at data from BRFIS, or the Behavioral Risk Factor Surveillance System, they were trying to overlap what local jurisdictions then accounted for the highest number of HIV cases or incidents within the United States. And what they found was that there were 50 local jurisdictions and 7 states that accounted for over half of all new HIV infections within the United States. So these 50 local jurisdictions tend to be more county or city level. So if we think about the city of Los Angeles, Miami-Dade County, with of course encapsulating Miami in that area, San Juan, Puerto Rico, that these areas were known for their high number of incidents, but also given the urbanness. And what they found was there's a disproportionate burden also within 7 states within the US that have disproportionate rural occurrences within that. And Oklahoma is a top 7 state, I guess we could say. And so this was kind of based off of data that colleagues of mine at CDC were working on. They looked at these 7 states. And so Alabama, Arkansas, Kentucky, Mississippi, Missouri, Oklahoma, South Carolina, essentially the majority of them being southern states, that in assessing, well, how does HIV testing correlate then with HIV incidence within that? Kind of assuming that if we have lower numbers of HIV testing, means we have much more individuals unaware of their diagnosis, which allows for disease spread. And so when you look at Oklahoma here highlighted, that only about 30% of Oklahomans have ever had an HIV test anytime in their life. And then within rural communities, it's less than 28%. But when you look at those who've been tested within the last year, Oklahoma has the lowest HIV testing, and both indicators for the last year is less than 7%, and within rural counties is actually less than 6%. So if we know that there is kind of this disparate impact within our rural communities, and that testing is one indicator that we need to address, well, how can then we enhance some of these preventive measures like HIV testing and different parts of prophylactics as well. And so some of the work that we've done, and this kind of mirrors kind of our current projects to give back, has looked at what are some of those barriers to access. And so pre-exposure prophylaxis, which is a once-a-day medication that high-risk individuals can take to prevent HIV acquisition. It's about 98% effective when individuals takes it regularly. Has been modeled by Health and Human Services as an important way to address the HIV epidemic. But we found is there is very low uptake, especially within Oklahoma, and even more so within rural Oklahoma. So we wanted to evaluate, well, what was causing this? Part of it is just this breakdown with this care continuum, geographic isolation of individuals. You have areas related to access to providers, and then especially individuals who might be providers that provide affirming care, combined with limited HIV and STI screening and stigma. This all coalesced together to which drive numbers down. And so you had men discussing about the fact that equating it to birth control, to where providers felt if they prescribe this, then they're endorsing their patient's sexual behavior, essentially not wanting to prescribe. And we've seen this before, first working in Oklahoma, MDs and DOs that I met with that were infectious disease docs, working with HIV positive patients, were actually not willing to prescribe PrEP. And part of it was they felt like it was outside of their scope of practice, and it was endorsing individuals to engage in a risk behavior. So we weren't really taking that harm reduction approach to it. And luckily we start to see some modifications with that. But in order to, understand, and get increased routine screening, but also to find out if a person is a good candidate for PrEP, well, part of this then is based on the fact that our patients have to feel comfortable and disclose either their sexual orientation or their sexual behavior to their patients. And so we wanted to look at, well, what are some of those predictors in a state like Oklahoma, where we have a social conservative nature to it, of individuals who are willing to disclose their sexual behavior, sexual orientation to their medical provider. And what we found was that for every decrease in age, there was an increased likelihood that someone would disclose. We see this to be, it makes sense given social norms. The younger you are, you have been grown up in different norms related to sex and sexuality. We've seen those changes, but also kind of your comfort level of disclosing would impact it. If you're not out in your day-to-day life, you're less likely to also disclose to your provider. What was the most interesting thing that came out was looking at the difference between medical providers and mental health providers. When it comes to mental health providers, about a little over 90% of participants were willing and have said they would disclose their sexual orientation or sexual behavior to a mental health provider. But when it came to their primary medical provider, it was less than 40%. And so that's a huge gap. And most of this came from fears about rejection from their providers. We know that mental health care is built on this relationship that you build with your therapist or psychologist. So you are starting to engage in some of these deeper questions at the same time. But we also know that we need then to create health programming and training for future physicians or physicians in general to build those comfortable environments that enhance disclosure. And we see this play out further when we start to look specifically around stigma. So this was a part of a larger funded qualitative study that we had looking at the impact of stigma and other determinants on health outcomes, to which Kyle and Hunter, both DO and PhD students, were part of. And so when we were looking at structural stigma, we were looking at how things were occurred in the social societal level and the cultural norms and how they impact individual level behavior. And we started to hear this same kind of story over and over again when it came to physicians. This man who was getting care just outside of Barnesville in a small town, it was kind of a community clinic, went in there, had been open about his sexuality, told the doctor to have that open conversation. The doctor gave him a card or flyer about going to the church and told him that maybe he should go down there. And so we had that one example, and then we had another young man that was in southeastern Oklahoma talking about the fact that he had a negative experience with the physician when they brought up their sexuality. And since that time, when he goes to see new providers, he feels like he has to be more private. And so he sometimes is not telling the truth. And so if we're looking at how we can come to best practices of care and meeting the needs of our patients, if they feel like they can't even tell us or they've had a negative experiences that are now influencing their likelihood of telling you, we're not getting the whole picture of that person's health profile and screenings and care that might be needed. Similarly, we live in a state where there might be a stigma about talking about sex at all. And there is a stigma attached to sexual health, like getting tested. And then if you're also a sexual minority, that's an added layer of conversation to occurs. And similarly, that when you feel like you might not have individuals that are like you within your community, you could feel socially isolated. So a lot of these men are isolated by chance, not by choice. That these are individuals that have been born and reared within rural areas, do not have the financial ability to move into a larger urban area. They describe kind of that's where they feel like would be much more hospitable, or they would get better quality care and have more of affirming environments, but they're kind of restrained to where they currently live. And so we understand that there are these barriers to care around physicians too. Well, what can we do to start to address some of these other factors? And so we can put into place sexual health programming, but this programming has to be available, accessible, and acceptable. We need to have it within our communities, and not within our urban communities, but also within our rural communities. We have to have individuals who can access it. So if we know that transportation could be a barrier, COVID, how we utilize telehealth, telemedicine to go ahead and leverage these programs, but they also have to be acceptable. Understanding the fact that, is the way it is affirming, does it work within their hours? Does it kind of meet their needs? And so we can look at these evidence-based programs that are culturally relevant, community engaged, but address these unique barriers. And so we've done some work looking at this. So for anyone who has worked on main campus, well, I guess on our campus in general, we think about the One Is Too Many initiative that we have across the OSU system, looking at sexual violence on our campus. And so One Is Too Many, of course, has the sexual assault prevention program to where all students have to take the online module and pass it before they can enroll in classes. Faculty and staff had their own module that they also had to do. And so we were looking at students' perspectives of saying, does this actually work? And unfortunately, when we mandate something, if it's something we have to do, I think of it when we have to do our HIPAA trainings or people who are doing human research subject, when you have to do your city trainings, we feel like it's one more hoop we have to go through, and sometimes we don't pay the attention like we should. And so what we found were students were not grasping that material, but really felt that it wasn't adequate in the fact that it doesn't address the larger sexual health needs of students. And so under putting together then programming, working with our collaborators that are on the main campus, we're developing sexual health programs, looking at piloting at-home HIV testing as part of a larger STI testing within a college environment as a larger comprehensive sex ed and sexual health program that we can then play out. We've also then looked at how men, in particular sexual minority men, want to be outreached to and engaged within prevention programming. So looking at some of these traditional avenues we use, everyone likes to use a good flyer, advertisement, but one of the issues that you have is that traditionally we try to use symbols that make someone say, this resonates with me, or this is for me, even before we go ahead and grab it. And so for sexual and gender minority individuals, this could be the use of a rainbow flag or a rainbow, or some type of symbolism that would grab someone's attention. What we find is, of course, that there's a disconnect between identity and behavior, that these individuals might not identify as gay or bisexual because that's more of identity, but they're still having same-sex partnerships with other men. And so when we use something like a rainbow or the like on a flyer, it might not gravitate towards them, and they might be actually fearful to take it because it could inadvertently out them. Similarly, when we're thinking of development of health programs, they want more larger scale programs that address all men. So that way it encompasses gay, bisexual, and heterosexual men. So that way they also don't feel inadvertently outed, which could lead to social or physical harms within their community. And this is different to what we see within more urbanized area where there's a lot of focus on community building and bringing a smaller segment of the gay or bisexual men together in order to address health issues. And so we know that we can develop these programs, we can engage people within work, but one of the largest factors that we see is that we all have to come from a solid foundation. When we think about health, what is the education that we received during our formative years, and then how do we build off of that? What we see within related to HIV and STIs, especially for sexual minority men, is that they didn't receive good sex ed. It wasn't really relevant to their needs. It was very heterosexual focused. Within Oklahoma, of course, if we think about HIV as an example, HIV mandates and curriculum related to the HIV education requirement in Oklahoma has been updated since the late 1980s when it got brought to the state legislature a couple years ago. 1 year it did not get out, next year it got out, it was approved, and then it was vetoed by the governor, and it has stalled ever since. So we're still running off of an education mandate which talks about basic information that must be taught about HIV that hasn't been updated since the 1980s. And fortunately, a lot of things have changed since then, but we now know individuals are getting that. So when I talked to Micah, we wanted to have about a 30-minute presentation and questions, all that. So I really wanted to take some time just to talk about opportunities for students, but also faculty, staff across the area that we can have for collaboration if it intersects with people's work. When we think of students, one of the big things is about a focus on training, not seeing this as an output. We want people to have that light item on their vita, but we also want students to have a thorough understanding of what research looks like and how you can apply that within your own setting going on. So we have opportunities within data collection from doing in-depth qualitative interviews with individuals, all being done via Zoom, via COVID at the moment. Implementation of online questionnaires, use of secondary data sets, use and learning of qualitative and quantitative analytic programs like Deduce, SPSS, SAS, and the like based on someone's comfort level, but then developing some of these dissemination pieces that are important for stakeholders and for academia in general. So development of research and policy briefs, presentations to community stakeholders. We'll talk about a couple of projects that have going on and how they're really community driven, development of abstract development for conferences, and then manuscript development and submission too. So kind of that large continuum and meeting students where they're at. We also want to make sure that people are part of an interdisciplinary collaboration and have an interdisciplinary mentorship. So the Sexual Health Research Lab, which I founded when I came in 2014, is actually dual located. So we have a site here at CHS, and we also have a site on main campus with Dr. Rose and Dr. Mahaffey that lead that. And so we have local lab meetings for our team here with Dr. Giano and our GRAs and all that, but we also have monthly OSU system lab meeting with our colleagues over there. We have interactions with experts within the field related to sexual health and infectious disease, development of your vita, how to start writing a grant narrative, where it could be, and also interaction with students and GRAs from other programs. So currently we have 2 Masters of Public Health students that are full-time GAs with us and a counseling psychology doc student. And given COVID, we have more interns this year. So we have an intern with us from Yale, and then ECU, and then UCO, who come from pre-med to a sociology background. So you have that diversity that's occurring there. So some of the current projects that we have going on, this project will be launching on October 1. It was funded by OCAS this year, looking at that HIV STI burden that I kind of discussed. We are rolling out and engaging 18 and 25-year-old men within Oklahoma, understanding that's where HIV and STI numbers are higher, but we have less uptake. And we're going to evaluate and pilot efficacy of an intervention that includes HIV and STI self-sampling and asymptomatic non-routine testers. So individuals, we'll be recruiting 300 people over 3 years, 100 Native men, American Indian men, 100 men who have sex with men, and 100 general population men to utilize a at-home HIV and STI sampling kit to where they will then send those samples back to us here at the lab with Dr. Call, where we'll process the results, and they'll get the results by either text, phone, email, or database depending on their preferences. But then those who have a reactive test results will be linked to a telemedicine appointment with OSU for treatment. And so we'll be interviewing men about their experiences with the telemedicine, their experiences with self-sampling. And the second aim of this intervention is an mHealth intervention to do HIV and STI prevention. So half of the sample receive kind of prevention as usual. The other half will be enrolled into a 6-month mHealth intervention, essentially using an app, which will have daily diary questionnaires about mood, behavioral, and like, but it has ingrained educational opportunities and using gamification. So that way people are doing little modules in order to earn points, in order to kind of disseminate some health information too. We have some COVID related projects at the moment too. We have an NIH funded program that's looking at COVID in relation to risk and resilience behavior among substance using adults in rural Oklahoma. So we'll be interviewing 60 active substance users in rural Oklahoma to assess knowledge, risk, attitudes related to COVID, and how COVID then impacts their interaction with harm reduction programs, getting screened for HIV, hepatitis C, and their engagement in care, but ultimately to kind of inform the development of public health messaging that could be used in the next epidemic that we have to reach this vulnerable population. And so that will be analysis of qualitative data that we'll have through these 60 individuals, and then be reporting out a report to the funder and then dissemination in academic sources. We've been asked by the state epidemiologist to look at the unique needs of school personnel who are being impacted by COVID, especially looking at teachers, school staff in the K-12 who are come in contact with someone who's been diagnosed with COVID and then been placed into quarantine. And so essentially, teachers have been defined by the president and the administration as essential workers, which means that even if they come into contact with somebody who has been, if they've been exposed, that we could bypass the quarantine and they would have to go back to the classroom. Currently, the governor wants to make the best approach based on science. And so what we're exploring is looking at the number of days to when most people would test positive, so we can have a better understanding of, do people need to really quarantine for 14 days, or are most individuals testing positive by day 10, so we could have you go till day 10, you've had 2 negative results, and now we feel comfortable to lead you on. So we'll be recruiting about 1,000 Oklahoma school personnel across the state. This project has just launched to where they will get screened for COVID on day 5, 7, 10, and 14 from a local pod, and then they will take daily diaries around their symptoms, mood, and the like, so we could better understand impact of COVID and being impact of quarantine, but also this will kind of impact Oklahoma policy to how long people actually need to quarantine for. And so we also do a lot of needs assessment and quality improvement programs. And so this one might be especially interested students who are looking at barriers to care. So in McCurtain County, where of course we have negative health outcomes that we see, but some primary data show there's a lot of medical distress of the local hospital, but also providers. So the state health department is having us interview physicians and members in the communities to assess barriers to care, medical system distrust, and the like. And so that project will be occurring within the next couple of months. And then we're also working with, in northwestern Oklahoma in the Eden area, I'm part of addressing the rural HIV epidemic. They've received a HRSA planning grant that has a component of doing a detailed needs assessment among community members, but also providers related to HIV prevention care and the care continuum. But we'll also be implementing education and training activities for physicians and other care providers within northwestern Oklahoma in order to enhance HIV screening, but also linking people living with HIV to prevention and treatment options. We do also have a large number of projects related to secondary data analysis. So Dr. Gano has led a lot of these efforts there related to YRBS, BRFIS, the National Survey on Drug Use, and the National Immunization Survey looking at teens. For example, within COVID-related data, we've been working with colleagues at other universities to look at differences for COVID case fatality rates, mask policies, and within the rural-urban continuum. Zach has looked at a lot, especially for sexual and gender minorities, around suicidality. So using YRBS data, not only do we want to look at the fact that LGBT youth are more likely, 2 to 3 times more likely than their heterosexual peers to attempt suicide. Well, what happens when you have different type of behaviors or situational things occurring? And so, if you're being bullied, if you're using substances, if you're having poor grades, not getting enough sleep, what do these kind of coalesce together? And so using latent profile analysis, he's done some work here that just came out in the journal Adolescent Health, looking at the profiles of those LGBT individuals who have attempted suicide. And what we find is that if you have high levels of bullying and substance use, that these LGBT youth are 17 times more likely to have attempted suicide compared to your peers. And so how do we then develop interventions and programming to have teachers and others aware of looking out for bullying and substance use, especially within this community? We just had this come out last week, looking at adverse childhood experiences. So this is the largest known data set of adverse childhood experiences data. It's from 34 states. of the 36 that collected, 2 did not want to give us their data. So a little under 200, over 211,000 participants. And what we see is within these adverse childhood experiences, an array of important findings that over half of Americans have had at least one ACE. About a quarter have had 3 or more adverse childhood experiences. So this could be physical abuse, parents incarcerated, divorce, sexual abuse, and the like. Communities of color are more likely to experience ACEs, and so have people that are sexual minority. And finally, given that we know for students, it's important to have that clinical opportunity too, that we have a number of projects that are with the internal medicine specialty services. So Dr. Ladd, Dr. Baker, Dr. Som and that group, especially related to HIV care. So currently we have a program with HRSA where we're implementing and evaluating a telemedicine program to do rapid HIV test and treat. So where people who have had a preliminary positive rapid result within 2 days have a consult with Dr. Ladd and been put on antiretroviral therapies in an expedited fashion. So we have a number of opportunities, and hopefully this kind of gives an overview of some of the work that we're currently doing, but also shows opportunities for students and colleagues also to be involved. And so I definitely want to be respectful of time and open up for questions too.
Hi, Dr. Hubach. Can you hear me okay?
Yes.
Okay. Thank you for the talk. Super interesting stuff. I had a lot of students reach out to me and say that they wanted to come, but there were some scheduling conflicts, so they weren't able to. But some of the first years especially were curious because they're swamped right now, if you're going to have opportunities over the summer to do research.
Mm-hmm. Yeah, and I know Dr. Vesser and Dr. Hartwell are recording this, so I think this will be available for students too. But yes, so we've had students that have done the 3rd, 4th year research rotation with us, especially for first years that'll have that second year, that summer free. There's definitely opportunities for secondary data analysis, but within the OCAS testing project and the like, that students who might be interested in, especially in that summer month, if we just start touching base earlier, that'll allow us to kind of slot students in, especially opportunities where we might be able to hire them as an hourly worker. Sometimes we have projects that allows for that.
All right, thank you.
No problem.
Hey, Dr. Hubach, that was an awesome presentation. Thank you very much.
Thank you.
Hey, I was curious, like, if you could talk about kind of the research project life cycle, like all the steps and which steps are areas that you typically like need help with graduate and medical students. And I'm thinking of, like, you know, from the time that you know, you've got the initial kind of research question idea, and then maybe you do a literature search using Scopus and Web of Science, other library resources, and then like maybe you apply for grant funding from NIH. Maybe you need to go through IRB review or an IRB protocol review, maybe before your grant application. And like, if you could kind of like walk us through like that whole thing, and then at what steps do you need help from students?
Yeah, we, you know, those projects that I highlight are things that you're right, they're already at the point where we're ready to roll. But we currently have other, so projects right now that where we'd have students involved in literature reviews, but also grant development. So one of them being leveraging community health workers, especially with tribal entities, to look at the use of CHW, CHRs, to provide COVID-related education within, we have partners in Texas and within Arizona with various tribes. So that would be pulling of literature, if they can be part of grant meetings, really learning the process of developing of grants there too. So during that formative page, then we go after funding. We have a couple projects that'll be going up for IRB. And so students who want to learn that process, of course, all students will have to have city training anyway. for human subjects research, but learning kind of ins and outs related to ethics and protocols within that area. We've had students work on development of code books or interview guides for the collection of qualitative, quantitative data, to developing and implementing, building those data sets in REDCap or Qualtrics, and the like in that realm, to then where we're ready for data collection. So one of the biggest things that we are needing are individuals who to conduct interviews. And so if we think about taking your practice as a student physician of interviewing and collecting data from individuals, especially that recurrent county project, it'd be a great opportunity to just really have a discussion with community members about what they expect within their clinical care, what are some of the barriers to care, and how a provider can make for a better experience with them. And so those formative things, we have those opportunities, and then at the end slot, depending on where projects are at, are really trying to teach individuals data collection and data analysis techniques from qualitative to quantitative based on someone's skills. And kind of the big thing for us is finding out what you want to learn, how do you want to apply it, and what's kind of the end goal, and how much time do you have. So for students who are able to have a little bit of time for a longer period of time, we've scoped out variables or data that they can have some ownership on. So we have a larger data set. They might be interested in how X is related to Y. And then they've worked with Zach and I to kind of build a paper off of that. That's an experience that our DO students that have worked with us with in the past too. So yes, there is that Y trajectory, and kind of depending on what that experience you want to have, will build you into a project that is at that pace, because we want it to be mutually beneficial and for you to get that mentorship. Thanks, John. I appreciate that.
Thank you.
Randy, this is Frank.
Hi, Frank.
How you doing?
Good.
I had a question more relating to your, specifically to some of these projects that you talked about. Mm-hmm. Given the hesitancy of LGBT individuals to be candid with their primary healthcare providers, how do you go about getting subjects for your studies in Oklahoma?
It's a long, tedious process.
I suspected that.
It's a lot of relationship building, and one of the things that we started early on is once we have those relationships we've built, people can opt in for us to keep their contact information, so that we're able to but reach out to them again. Right. One of the things that we thought is, a lot of times in hidden populations, we like to use responded-driven sampling, to where a participant then brings other people of their network into the study too. We usually would incentivize it. So if you bring in, for every person you bring in, we'll give you an extra $5 gift card. What we found, especially within this community and rural area, is there's kind of a hesitancy to do so, because this is kind of their very limited social and sexual network. And so there is this perception that by bringing that person and saying, oh, you should be part of this study, you cross a boundary that you don't know sure you want to do. And so we found that not to actually work. Back in the day, some of the technology things like Craigslist, before they tore that side of the site down, we've used geosocial networking applications for recruitment. But a lot of it has just been trying to work with popular opinion leaders within each community to try to disseminate. And so it will depend on, it also depends on the time of year we have found as well. But I will say it is not the quickest. The thing about social behavioral research is that for a lot of it, we can't put up a survey and get a large number of respondents within a couple of days. Unfortunately, a lot of these projects take a lot of time, and building that trust is of the fundamental importance. And once that trust is broken, then you have a hard time rebuilding it. I think it's similar for individuals doing work with tribal communities as well here in Oklahoma, where there might be some distrust within systems too. But yeah, Frank, to kind of give you the snapshot, it is not an easy thing to do.
I suspected that. Yeah. Well, thank you very much.
Thanks. Any other questions, comments, concerns, frustrations, anxieties?
So I do have one more question for classmates who are interested but might not have lots of research experience yet. Would you still encourage them to reach out to you?
Yeah, like I said, we expect students from all stages, all processes. And so it's kind of looking at where your knowledge base is at, and then kind of tailoring some of that educational component to it. But we have started students who feel like they are ground zero, with literature reviews, or if they really want to focus on their interaction with potential patients, of even development of interview protocols, but also conducting interviews, because the data, that facilitating of gathering data is so important, and it doesn't feel as researchy because you're really just having a good conversation with someone. So yeah, if someone feels like they are a research novice to a research expert, we're happy to see where you're at and plug you in.
Thank you. Yeah, and I think I'm one of those that started off with no publications when I met you, and was able to get some publications, but also some high quality mentorship and a good understanding of what research is all about. So.
No, I think all of these are great opportunities, and so all the faculty, I think the office is highlighting, are important to show the diversity of all that's being done on our campus, and understanding some things will take time, especially if we think of social sciences and med sciences. Those research products could take a little bit of time to get out.
Well, thanks, Randy. I appreciate your talk. I think it was very informative for the students. And just on a personal level, I've worked with the Office of Rural Health, Dr. Hubach, Dr. Wheeler, and recently met Dr. Giano, and all of them are very personable. They are down to earth and easily approachable. So any of the students who are watching this later or were impressed with what they wanted to do and get involved in the Office of Rural Health, or Dr. Hubach or Giano or Wheeler's work specifically, feel free to reach out to us. Everybody should be aware of the Med Student Research email by now, and we can act as, I'm Dr. Micah Hartwell, Dr. Matt Vassar, and Dr. Tully Jacobs is on here as well. We can act as liaisons to get you set up with any research path that you want, whether it's Dr. Hubach or Wheeler or Giano, or the other presentations that we'll have coming up. So look for future emails about upcoming presentations, and keep in touch with us if you want to get involved in research. So again, thanks, Dr. Hubach. I appreciate it.
Thank you all for being here. I appreciate it, and look forward to seeing you virtually across campus.